I did my course report on the doctor of medicine and the important role they have in medical terminology. A doctor of medicine is typically referred to as an MD. So you'll see those initials after someone's name, like John Doe, MD. They're a medical doctor. They're a doctor of medicine. And they have an important role when it comes to medical terminology, more so than other healthcare professions, because typically they are at the top of the medical model. So the first slide just says doctor of medicine, psychiatry. Then the next you have physician-guided treatment. So coming from working in a hospital setting, I'm very familiar with this term. So in a hospital setting, the physician is at the top. And then you have nurses, and you have therapists, and you have social workers, you have mental health techs. So the physician is at the top of the treatment model. And what we mean by that is we can have a multidisciplinary treatment team, but the doctor sets the tone. And it's a top-down approach because you have collaboration from multiple specialties, including therapy, social work, and nursing. However, the doctor sets the tone for what the treatment modality is going to be. So, for example, if a doctor says, okay, this patient has bipolar disorder, that triggers the therapist to provide the appropriate treatment modality. And then we have clinical and non-clinical healthcare professionals that are involved. So going back to the idea of multidisciplinary. Now, because someone's not technically from the medical field, like a social worker, that doesn't mean that they don't have an impact on treatment and medical terminology. So, for example, if a therapist says that they haven't been sleeping for a long time, they have these really crazy ideas about how strong they are. They gave away all of their belongings. They're fighting with everybody. They feel like they're Superman or Superwoman. Even though those are layman terms, anyone can really understand the words that were just said. That's an indication of mania. So a doctor would be able to hear that and say, okay, that's mania. That's an indication of mood instability. So that would trigger the doctor to provide the appropriate medication regimen. And then that would trigger everyone else to basically be on the same page. So just because non-clinical people or non-medical professionals are in the treatment team, that doesn't mean that what they say doesn't have an impact on the medical on the importance of the medical terminology that's being used. So layman to clinicalese. I use this term especially when it comes to family members and explaining what's going on with the patient. Usually we go the other way around. We go from clinicalese to layman terms. But when it comes to medical terminology and providing care, we want to make sure that we can translate it back as well. So it's not a one-way street. This really becomes important when it comes to the appropriate diagnosis. So if you have, like the common examples I used in my report were borderline personality disorder and bipolar disorder, and schizophrenia versus schizoaffective disorder. Now, presentation-wise, if you had 4 people, maybe let's say 4 people total, 2 of which have the borderline and the bipolar, and the other 2 have the schizophrenia and the schizoaffective. Each pair would be similar. They would present in a similar way, but there are fine nuances between each one that would indicate what type of medication regimen is effective. So bipolar disorder has to do with mania and depression, and the mania acts as a fever on the brain. The brain is overworking itself. It's causing lack of sleep for days on end. It can result in psychosis, especially in bipolar disorder type 1. Borderline personality disorder can have mood lability, but it usually happens in bursts. It's not happening for days on end. It's called emotional storming. So let's say that a physician is interviewing each patient, and at that particular time that he's interviewing the patient, they both present with mood instability and mood lability. However, it's about what does the overall picture look like. And maybe the doctor won't be able to get the whole picture. That's why they have to rely on the multidisciplinary team, like the doctors, like the nurse, like the nurses and the therapists and the social workers, because they provide an alternate perspective. But ultimately, it's up to the physician to take the reports from the staff and put it all together in one comprehensive picture. And then we have, schizophrenia versus schizoaffective disorder. So schizophrenia, by definition, is a thought disorder. Schizoaffective disorder has two components. You have the thought and you have the affect, you have the mood. And basically, it's like a combination of schizophrenia and bipolar disorder together. So they both have, similar symptoms, but the course of treatment will be different. The type of medication regimen is going to be different, and even the disposition. So why is it important? It goes back to chemistry. Simply put, it goes back to chemistry, but it's a lot more complicated than that. The reason I say chemistry is because this all has to do with the brain and the way that the neurotransmitters are impacting each other. So in a person that has depression, their dopamine receptors are going to be functioning differently than in a person that has schizophrenia. So in a healthy brain, the dopamine is flowing freely. Just very simply put, it's flowing freely, and it interacts with the receptor, and it has a healthy balance. And a person with schizophrenia, over a long period of time, these receptors become deformed. And in some brains, they either latch on extremely tight, or they don't latch on at all, or when they do try to latch on, that receptor is so deformed from years and years of neurocognitive decline. So the impact of dopamine can vary so differently from person to person, depending on predisposition, depending on family history. There's many factors that are involved. Then you have comorbid medical conditions. Comorbid medical conditions could be diabetes, could be a urinary tract infection, could be hypertension that could be impacting the patient's presentation. And on the more severe level, it can even jump into the realm of neuropsychiatry. So if you have a traumatic brain injury or a stroke, frontal lobe dystrophy, these are all things that can have a severe impact on someone's behavior. So like a person with frontal lobe dystrophy, I had a patient that had that before, and this guy had a great life. He was high functioning, everything was fine. And then he developed this, and he started behaving in ways that made it was ridiculous. It made absolutely no sense. For example, hitting a car and then just driving away, speaking very vulgar to women, arguing with people, arguing with chairs. And he wasn't schizophrenic, but he had his frontal lobes were deteriorating. They were dying off. Frontal lobe dystrophy. The muscles in the brain were just dying. Not muscles. I'm sorry. The brain tissue was dying off. So that of course had an impact on his behavior and on his presentation. So it was not schizophrenia like organically, but the way that it presented had very similar symptoms. So again, it's very, very important that we're familiar with the medical terminology across records. And how would we know that unless we reviewed the records, unless we got the information from other healthcare providers? So this all leads to, what are the treatment recommendations? So this can lead to what is the appropriate medication regimen, what are the appropriate treatment modalities, and ultimately what is the expected disposition. So what that means is, in terms of expected disposition, is if I have a patient that has a chronic schizophrenia, a long-term condition that is only maintained, not cured, what kind of disposition am I going to expect from this patient? What am I going to expect of them in terms of functionality, in terms of personality, in terms of attitude, in terms of mood and behavior? What am I going to expect of someone with schizophrenia versus somebody with major depression versus someone with anxiety versus someone with panic attacks? So the treatment recommendations and the treatment considerations are all come from an appropriate assessment, all come from proper communication. And the medical terminology is so important to abide by, so that way we make sure that we have the right information. Now, when it comes to psychiatry, this field is so complex because it involves so many people. You know, typically a primary care doctor will just work within the office and just, with his or her people. And that's pretty much it. Maybe with schools, they'll, write a return to work letter or something like that. But when it comes to psychiatry, we have so many different moving parts. So typically, a psychiatrist will send off the recommendations to a therapist, and the therapist may send off the recommendations to a school, and the school may make educational considerations. Or for adults, the reports from the doctors will impact a person's ability to get Social Security. So if the correct terms are not used across the board, then it can cause a lot of miscommunication. And the last thing that we want to happen is to impinge on someone's rights, is to hinder someone's ability to get the services that they need. And on the flip side of that the last thing we would want to do also is to increase the stigma. So if someone doesn't have psychosis, if someone was just having, grand thoughts, ideations, but not grand delusions, that there's a big difference between the two, and one would indicate psychosis and one wouldn't. But if someone is not familiar with the terminology in conjunction with the rest of the patient's clinical presentation, then they could potentially give them a diagnosis that could be detrimental to their future.